I'm Andy Orm of O'Reilly Media. I'm talking today to Khaled El Emam of the University of Ottawa and the Children's Hospital of Ottawa. Khaled is an expert at de-identifying data, which sounds like a rather narrow and perhaps boring topic. But I'll tell you, at this conference we're at, Strata Rx, all the speakers are saying, let's get more clinical data. All these hospitals, all these insurance companies, let's release more clinical data. And they can't do that ethically or legally unless it's properly de-identified. And we're going to hear about that crucial topic today. So welcome, Khaled.
Thank you. Thank you for inviting me.
Yes. I understand that following the HIPAA rules, the 17 or 18 rules, is not always the right way to de-identify data.
Yeah, so HIPAA has two standards for de-identifying data. And I think across many jurisdictions, HIPAA is the most precise, has the most precise regulations on how to de-identify data through these two standards. So the first standard is Safe Harbor, which specifies these 18 elements that you need to remove or generalize in your data set. The problem with Safe Harbor is that it often removes fields that are important for analytics. So it removes temporal information and geospatial information. And for a lot of data analysis, you need to know the order of events, an adverse event occurred after taking a particular drug. So temporal relationships are quite important. And of course, also geospatial information is important when you're doing, for example, any kind of public health analysis. So Safe Harbor takes that information out, so it reduces the utility of the data. On the other end of the spectrum, it's very easy to create Safe Harbor compliant data sets that have a very high risk of re-identification. And a good example of that would be longitudinal data that has a pattern of visits of patients over time. So these can be compliant with Safe Harbor, but still it's still easy to re-identify patients in those data sets. So from a risk management perspective, Safe Harbor is not a very good standard to use because it only really makes sense in a very narrow set of conditions, which are not very common. But the second standard in HIPAA, which is the statistical method, or known as the statistical method, is more appropriate because it allows you to adjust the de-identification to the context of the data disclosure.
So tell me about a recent project you did where you were de-identifying data and how you figured out which is the most sensitive and how to properly treat each set.
Okay. Well, we do a lot of de-identification work. So over the last 3 years, I've been involved in close to 100 different data releases that were de-identified. But one that's recent that is public is the Heritage Health Prize. So I'll talk a little bit about that. For the Heritage Health Prize, we released data on 113,000 patients. It is longitudinal data over 3 years. And the data set contains claims and procedure codes as well as some drug information. So because this was a public data set, the standards for the identification had to be set quite high because anybody in the world, and it turned out to be that many people around the world were downloading that data set and doing analysis on it with the hope of winning the grand prize. So the types of things we did were, for example, removing information about patients that had sensitive diagnoses, HIV, substance abuse, abortions. So these are really highly stigmatized type conditions that we felt we just get them out of the way to start off with. And then we measured the risk. So over time, we've developed a set of metrics to precisely evaluate the re-identification risk for different types of attacks. So we measured the risk, and whenever it was high, we'd make some transformations to the data by generalizing some fields or suppressing some values, and until the risk was acceptably low, and then we put out the data set.
Well, it sounds like when someone takes a data set that has supposedly been de-identified, they should know how it was done so that they understand what kind of research the data is good for.
Absolutely important, very critical. You have to be very transparent about the de-identification methods for that reason, but also for just for ensuring transparency and to let the patients know that good practices were followed. Hopefully, the good practices were followed when you were de-identifying this data. So I think the transparency is very important. And if the de-identification is done well, then the data set should be useful for basically any type of analysis afterwards. Good identification should not limit the type of analysis that you can do on the data set.
But for instance, if you're looking for a primary cause of death and you've taken out HIV information, you're missing something.
Well, if the objective is to look at HIV patients, then you'd create a data set specifically for that, and you'd wrap around it some additional conditions, for example, for the analysts who are going to be working on that data. But if it's an individual level public data set, you just have to be a little bit more careful about what you put out.
Now, you've told us one example of good de-identification. Can you tell us about some interesting mistakes? You don't have to mention particular projects, but what are some typical mistakes that have been made?
Well, what we know is that in a medical record, all the different domains are strongly correlated with each other. So your lab data is going to be correlated with your diagnosis data, with your procedure data, with your drug data. So if you release one part of it, it's easy to predict or infer the pieces that you did not release. So a good example would be if you release the drug data, when we've demonstrated this, that we can predict the diagnosis information quite accurately. So we've seen quite a few data releases where this correlation was not taken into account. So some folks will release, for example, prescription data, and then ignore the fact that if once I get the prescription data, I can pretty accurately predict what all the diagnoses were for those patients. And if I can predict the diagnoses, I can probably predict all the lab tests that were ordered for those patients as well. So I can fill in a lot of those gaps, and now I have a data set that has a much higher risk of re-identification than just the prescription information. So again, you have to be careful and take into account these correlations in the data to provide the appropriate guarantees to the patients that the data was de-identified.
This may also be a problem for an individual patient at some point, because some people in the privacy sphere are calling for segmented data, which means that the patient can release certain things to another doctor but not release everything. However, as you say, if the patient releases certain kinds of information, somebody can guess at other things that, like the diagnoses that went into that.
Yeah, I mean, this touches on a much larger issue around consent directives or disclosure directives, where patients can restrict who has access to their data. They can say, you know, this physician cannot see that part of my record, but can only see that part of my record. And because all the information is correlated with each other, you have to be very careful about doing this, because it may not actually be very meaningful to hide your diagnoses information but keep your drug information, because a physician or a healthcare provider can look at that data and predict your diagnosis even though you didn't provide that information.
Informed consent means a lot of education, it seems like.
Yeah, or I mean, the other option is if patients want to block parts of their record, then they should just block the whole thing, not pieces. So you don't have content-based masking of data. You just mask everything or nothing, because content-based masking may not be very effective without a lot of analysis, and people are just not going to do that kind of analysis.
Anyway, that is up to the individual doctor and patient to discuss, but it sounds like you are doing your best to protect the patients in the aggregate from the mistakes of researchers.
Well, I think there's an important element of patient trust as well. We know that patients change their behaviors when they have concerns about privacy. So they see multiple providers, they lie, they don't disclose information in their medical history, and that also corrupts the data. So from a data analyst perspective, you get lower quality data if the source of the data has been essentially corrupted. But we also see some physicians doing that. And a classic example would be, if instead of ordering one test that may be revealing of a suspected diagnosis, they may order a set of tests so it's hidden in a bigger set of panels. And that way the suspected diagnosis doesn't appear, it just looks like a regular physical. So again, this is a form of data corruption where individuals are doing this in order to conceal or mask information because they're concerned about their privacy. So, and the percentages who admit to doing this are alarmingly high. I mean, it's 15 to 17% of U.S. adults. When you look at patients only, the numbers increase quite dramatically.
Which is very costly, too, to order all those tests.
Absolutely, yes. So putting in place good practices to handle the disclosure of data in a way that's defensible and that will maintain this trust, I think, is very important. So also the public would support the disclosure of data for research and for all the analytics that we're talking about here.
Well, thanks for coming and explaining this today.
My pleasure. Thank you very much.